good.
We have a case on nurse case manager.
So the target audience.
These are administrators, behavioral health, public health specialists, providers,
So anything in there.
anything and everything.
I
Yeah.
think I just.
I think kind of one of the things we'll accomplish is discussing why, I don't know, discussing a little bit with Dr. Howe, just how it doesn't look like taking the requirement away is
I
really
think
making
it's
any
any
difference.
changes with the
Because
waiver.
what provider
you
wants
know,
to start doing something significant,
waiver.
new, with no training?
Yeah.
To do it, like, what is taking away the waiver requirements really do? So, and helping them kind of understand how providers are reacting to that change. So,
I'm not sure how many people are aware of the waiver change because I've spoken with some providers that said, oh, I can't do that.
yeah,
I think you can.
that'd be another thing we want to touch on here, and that'll be a good comment to bring up. That providers may not even be aware of that change.
I know they're having break and you walk around the table.
Yeah.
Just because they're maybe.
Yeah, and I've got this set to record, so they'll just have to like edit into different
Where are
videos.
our refreshments that we would get at the break?
I know, that's what I was just thinking.
We should have, I don't know if we had refreshments in this break. We have them in the afternoon. Did we? We should have brought some up here. In the afternoon, or we should bring some up here for the people that are up here. Well, actually, because there's only one. Yeah, and they come, there's one session in here, then the last session is only two, so there's nobody up here. So. We got booted out of the, we should have been in a conference room on the other side of our room, but they got booted out because Board of Trustees is eating lunch there. I think we're just, because we're getting ready to start, it would probably be more distracting.
But I say we give it just, let's wait till 11.
Yeah.
Add a couple minutes.
Yeah. You gotta follow that previous excellent breakout session. You got big shoes to fill now. That was really great. Good, I'm glad to hear that. Always put a lot of work into these conferences. You hope it goes well, but yeah, no good. Glad. That makes us.
Did you go to Ben's breakout? Did you go to Ben's breakout?
It makes us feel good. It makes us feel like we did good work with all the effort we put in. So we believe in the topics we've got today and the speakers, so we're excited. It's fun to sit through them as a attendee as well and hear some of the stuff. So. Are we out of time to win? I'll just start with introductions.
Yeah. Want to thank you all for coming to the breakout session on changes to medication assisted treatment. I want to go ahead and ask each of our panelists just to introduce yourself and share a bit about why this topic is pertinent to your work. And we want to start down here with Adam and then we'll work our way up.
All right, so I'm Dr. Adam Monk. I am a therapist. I work at Family Health Care. We do integrated behavioral health work there, and I'm on the MAT team, so we work with substance abuse, of course. And one of the things I really appreciate about that place where I work is, am I just describing me, or am I going the right direction?
Yep, you're going the right direction. Yep.
So one of the things that I get to do is when we meet with people who are struggling to overcome addiction and they're using the medication to assist, when they come into the room to meet with the doctor, they're also seeing the nurse practitioner who's a psych nurse practitioner who does the medications for the psychological stuff. They see the doctor for the physical stuff, and they see the therapist. So I'm in the room too. And so it's a nice crowd with the patient receiving the attention and being an integral part of the team. And so we work together as a team for everything that we possibly can to work together. My education and background, I'm also a substance abuse professional. So that means I work with the Department of Transportation, helping people that have violated some safety sensitive things and need to get back on track with safety sensitive work. I used to teach the understanding drugs, alcohol, and addictive behaviors course at Texas Tech University for a few years. And So that's some of my background there. My PhD is in marriage and family therapy from Texas Tech University. And I got my master's in marriage and family therapy from Utah State and my bachelor's in family science and psychology at Brigham Young University. So I'm not from Utah, but I came here for school. Then I left to go to school. Then I came back because I got married when I was here and my wife wanted to be near family. And family is important, so that's what we're doing.
And what area of Utah is your place?
Area of Utah? It's
What
right,
area of Utah?
right here in St. George. So just like a 5-minute walk down the road, if you walk fast.
My name's Casey Shakespeare. I'm the program director for the Utah Rural Opioid Healthcare Consortium. All of the individuals on the panel, their organizations are part of that. Dr. Howe's our medical director, and Dr. Press is a member of UROC, and then Family Healthcare's organization is also a member of our consortium here. And unfortunately, HRSA grants don't really recognize Washington County as rural, so it doesn't get to include St. George, but with their clinics and efforts in Iron County and Beaver County. So our consortium encompasses 9 counties. We have 2 different rural community opioid response program grants that fund the consortium. So, and actually I'll recognize too, Steve Jensen back then, Aspire 365 is also part of our consortium. But we service Beaver and Iron County, Garfield County, Kane County, Paiute County, Wayne County, Carbon, Emery, and Grand County. So we have quite a smattering with counties with very different population densities and personalities and things that we work with. And my background's in healthcare administration and public health. I have dual masters from the University of Utah. And kind of what my role with this all has been is as part of those grant programs, we have worked with incentive payment programs to get providers to become MAT waiver, which, as you can imagine, with the recent changeover from being required to have an MAT waiver to prescribe to no longer having that requirement, it kind of throws a little bit of a wrench into what we were doing, but we'd already made a lot of progress and kind of on the tail end of that anyways. But we've been able to get providers waivered who service all 9 counties. And increase the number of MAT waivered providers pretty significantly. I think we've, in our one service area, which is Beaver, Iron, Carbon, Emery, and Grand, I think we increased the number of MAT providers by 15, I want to say, 16 maybe, 14, somewhere in there. Oh, we got up to 15 because that was, we had a couple after that because we met our goal of 15. And then I think we've had 2 or 3 so far in our other service area, but it's a significantly smaller service area. So the numbers were projected to be smaller, but I think we've waivered now somewhere in the neighborhood of 18 providers to get waivered, and even a couple of those after that requirement changed. So that's kind of what my role's been.
I'm Beth Howell. I introduced myself in the last session. I'm at the University of Utah. I'm an addiction psychiatrist, addiction medicine specialist, and have been doing waiver trainings for years. Since probably 2002 or 3, and been prescribing buprenorphine relief pretty much since I came here to Utah. I worked in an abstinence-based program before that, and we didn't use it, and that's why I didn't use it right away. And then I also have a HRSA grant to train addiction medicine fellows, which includes addiction psychiatry fellows, and then work as the medical director, as Casey said, for UROC.
And I'm Lauren Prest. I'm an addiction psychiatrist, addiction medicine doc as well. I trained at the University of Utah. Dr. Howell was my fellowship director. She did my MAT waiver training. And this topic's important to me. I work in a rural area, Moab Regional Hospital. I work in an area where we haven't had a lot of success in getting a lot of different specialists waivered. But I believe in it, and I think it's part of the solution. So MAT is a big part of my life.
Well, if you guys can share for us, what are the current updates in the world of MAT? What should we be aware of?
Few things. With regards to the waiver, I mean, as Casey referenced, you can now file for a notice of intent, and you can treat up to 30 patients with buprenorphine without completing the waiver training. It's still recommended, of course, but it does open the door for people to have more immediate ability to help people without being specialists and without dedicating hours of time. The waiver training is also open now to more types of medical professionals like PAs, nurse midwives,
Mhm.
nurse practitioners. So, and they have different organizations that will do their waiver training besides just the physician groups. So in general, access to this ability to prescribe has really changed.
I think it's probably good. I don't know if everybody in the room is really familiar with how the waiver training works. So it might be good just to kind of explain that. So in what we've done with the providers, we've worked with Dr. RHAU and the Parker program and Connie Kitchens at the University of Utah. And I don't know if you guys were doing anything virtual before the pandemic, because we were going to do in person. We were getting ready to do our
We're
first
gonna do
trainings
live.
in person live, because there's a 4-hour component to it that's a live training that everybody attends to start. And I know we had in April of 2020, we were in the process with Dr. Hal and Connie of setting up that first one that was going to take place in, I believe it was Moab. And then
Boom.
boom, that kind of went away. And so we audibled, and we've actually worked with Connie to offer, I think, 3 rounds that UROC's participated in of trainings. And I know there's been other ones as well. That's just within our service area. But there's a 4-hour live portion to the training. And then the training's available, like Dr. Press said, to physicians, to nurse practitioners, and to PAs. And is there any, have they expanded that? Because those were the 3 groups that was available to before. Midwives, well, nurse practitioners. Or is it?
No, they're not
No.
all nurse practitioners.
Okay, not all nurse practitioners. That's one of the changes. But if you're a physician, there was an additional 4 hours you completed online on your own pace. And then if you were a PA or nurse practitioner, and I assume it's probably the same for nurse midwives, it was an additional 20 hours of training that you did online in person or on your own time. And then you submitted the certificates that you completed all that training into SAMHSA, right? I don't get into that part. I just tell them what to do and they send me a receipt.
Depends
But-
on who's, it probably was AAAP, but
Mhm.
anyway.
Yeah, you
whoever.
submit that you've completed it, and then they process the waiver and send it back, which that is also something else that took some time. And I know we had some providers that had some frustrations with getting their waiver back, because we wouldn't pay them until they got their waiver number to prove that they did everything. And there was a couple of them that it took them several months to actually get that number back, which they were a little frustrated with. Thankfully, not with me, but that it took them so long to get their funds back. And the way our incentive payment program worked is we just gave a flat rate $1,200 incentive. So they signed up with us and with Connie, and they did all the trainings. They submitted forms to us with their DEX waiver number, and then we issued them a payment.
And, you know, one of the things that's really, I think, sad, because it's not just with UROC, but also with other groups, is that physicians are the least interested in becoming waiver providers as a general rule. And the issue is very stigma related. I don't want those people in my practice. They're already in your practice,
That's what
dude.
my own doctor said when I
Yeah,
talked to him.
exactly. Yeah, and so, you know, the stigma is real. And yet the people who are really interested are the ones that are kind of more like in the practice on the front lines, front desk, nurses, you know, MAs, people like that. Not everybody can get waivered, obviously, but I think there's quite a bit of work to do to decrease that stigma. And so, you know, SAMHSA, the Substance Abuse and Mental Health Services Administration, their idea is we just need to get more and more people waivered. And this new change is to help. So for example, if Dr. Harris has a patient that's on buprenorphine and you're a hospitalist and you're discharging him, you can't write the prescription without an X number. And so now you could, if you just said, I'm planning to write buprenorphine prescriptions for up to 30 people, then you'd be covered and you wouldn't have to do any training. So, you know, but I can't say that even at the University of Utah that many people have taken up, you know, have submitted an NOI, a notice of intent to do that. So I don't know if it's really going to make that much change, because the issue has always been framed as we just need to make fewer barriers and have more people able to practice. But people are not like chomping at the bit to treat addiction. I'm sorry to tell them, you know?
Yeah, I don't know that it was the waiver that was preventing them from prescribing just in the first place.
Because
but-
as far as like people who, if you took all the waivered providers in the United States, 5 to 10% are regularly prescribing.
Mhm.
And that was before this change. So we have a big problem with lack of knowledge and also with stigma and many other factors too.
So can an MA administer it under a physician?
Well, it's usually going to be prescribed as an outpatient prescription. Every once in a while, you want to administer it in the office.
Yeah, that's what I meant.
But, you know, and for example, like if like at Operation Recovery or at your program you're developing, it has to be right now, if the person is dosing in the clinic, you know, because, you know, if they need more structure and they come in daily for methadone, they can come in daily for buprenorphine. It has to be an RN, and hopefully it will be expanded so that LPNs will be,
Mhm.
it's expanded good. And so, but they have to have a nursing license of some kind.
You know, Adam had made an interesting comment about the providers not knowing that the regulation had changed.
Just a conversation recently with a few of the providers that I work with that we were talking about prescribing buprenorphine. And they said, oh, I don't think I can do that. And
Mhm.
had conversations and they weren't aware of the changes.
I think sometimes they want to play dumb.
I think so too.
They like
Because
the waiver because they're like, oh, I'm not waivered.
I'm not waiver, I don't treat those people. And so
Well-
that's why I'm saying stigma is one of our biggest issues.
And even,
In your rural places, if it takes, you know, if you're a provider, if they just have MAs in their clinic, if they need an R, I don't know if that makes it harder.
It doesn't have to be given in person. Most of my
So-
people, they induce themselves at home. You give them instructions,
Mhm.
and they do it themselves.
Mhm.
but it is interesting to look at, you know, maybe an option, a better, more effective option to getting more people prescribing would be taking a look at who else in the medical community could actively participate in that. I know I could get Larry Garrett wound up going about what nurses could do in this case and go all day long. We could do a whole work session with that nurses are underutilized with the skill set that they have and what they could do. Yeah,
I'm gonna write a note right now. Thank you.
Yeah,
but
because even though nurses can't prescribe or whatever, they can definitely learn a lot more about medication for addiction treatment. We don't call it medication assisted treatment because we think that's in the field of addiction. We think that's a pejorative term because we don't say insulin assisted diabetes treatment or any other thing like that. Anyway, you can keep the MAT language, but it's medication for addiction treatment, which is what it is. And so, but nurses and MAs and really anybody in the clinic, even the person at the front desk who's just answering the phone and doing all the administrative stuff can make a huge, huge difference. So you've got to train people all the way. And then nurses, obviously, within their scope of practice can do so much with education and, you know, a lot of other things. So, and Larry and Linda Edelman and Zoe Robbins and a bunch of us have been working on some of these projects. Yeah, we
Yeah.
will. Keep trying to find the right source of money, but it hasn't come up yet.
well, and also even with our incentive waiver program, like we knew going into it that it wasn't, that we weren't gonna have 100% success rate on, you know, we got them waivered so they start prescribing. We knew that most of them were gonna take our money and run and probably never look at this again. But our hope was, you know, if I can get them to sit through 8 hours of training, we had some secondary programs. We have another incentive program that gets providers to participate in Project Echo trainings, which was also collaborating with Dr. RHAU and their behavioral health Echo series through the University of Utah. And then we also had another series that we've worked with Comagine Health on for the last 2 years. It's a 6-part series about how does it work to actually implement MAT in your clinic? And we've incentivized providers to attend that as well. So our hope was, you know, you can take our money and run with it, but whether you want it or not, you're going to have to learn about these things to get it. And our hope was that would help combat stigma and help get those providers at least thinking about that. But, you know, we still encountered that same stigma. I mean, I won't name the hospital, but there's still a hospital that wanted to talk to us about, getting any of their providers waivered and make the exact same comments Dr. Howe's saying. And, you know, it's like a steel door, a safe door, trying to get through there and just get them to even talk about it, and they just won't. And so there's still, even though we've had that success in getting more providers waivered, and we know at least those providers have got additional training here, you know, we still haven't been able to quantify how many of them are actually prescribing M18. It hasn't helped that there's been this major pandemic and that the providers are like stressed to the max already. So it's been really hard to push them actually to start using what we gave them, but we're hoping, you know, in the long run, it contributes to more providers actually starting to practice.
You know, one thing to put it in perspective is that, and anybody in medicine will know how horrifying this is. If you had a treatment that was effective and research-based and safe, that could save lives and help people, and it only was used maybe 10% of the time, that would be a scandal in any other specialty. So if, you know, because people are actually refusing to use the evidence-based treatments in addiction. And that would not be tolerated, but because our patients are very stigmatized and thought of as less than and not worthy of whatever, then that allows this to keep going on. It's one of the things.
Yeah, that stigma keeps them from recognizing. It's interesting how stigma works, right?
Oh,
Even
yeah.
though the evidence is there, I agree fully with that statement that if it were any other area, then it'd be a different story because of the stigma of addiction. They kind of ignore that evidence is there and don't get involved.
And even the patients themselves they'll self-stigmatize
yeah.
because they'll say, oh, I don't want to take anything like that. That's a crutch. You're just giving me another opiate, and that I'm not really, you know, abstinent with that. And trying to, you know, talk that through is extremely
Yeah.
difficult.
And getting that knowledge to the patient that that's available. I mean, how many patients even know, you know, if your provider's not willing to offer the treatment, how many patients have any idea that that's even out there as a help?
That's what I see a lot, especially in rural Emory County, you know, with that barrier being there with healthcare providers, it absolutely permeates with the recovery community and the clients that I see. I did a group once and I am totally behind MAT. I went to a whole conference and learned so much and was like, this is amazing, this is great. And I said something about it and they turned on me and I was like, oh, I am not in, you know, yeah. And so it was really interesting to see how the stigma, how they self-stigmatize with that too, and how there's just not really good information given for that population.
Well, Narcotics Anonymous, if you're on methadone or buprenorphine, they still don't allow you to share. I think that's still their policy.
No, they changed that.
When?
Just probably within the last year. And I only know that because my son-in-law is in NA. He's Utah's voice to the world for NA, and you can now share.
Oh, that's great.
Absolutely.
Okay,
And,
for many years though, and I
you
mean,
could not, absolutely.
methadone's been out since 1972
Yeah.
and buprenorphine's been out since 2002. And that's a pretty long time for them to change their mind.
I don't think that's permeating either. I mean,
Well,
my
I-
patients are kicked out of AA groups on a regular basis.
Well, I think that it's just like anything, it just takes some time to filter that down. Yes, I mean, I talked to your NA, the guy in Moab that does your NA meetings, and you know, we talked about that. I tried getting in contact with NA and Saleh so that they can do that.
But it does speak to the self-stigmatization that happens within, you know, SUD population.
Yeah, and it's just like buprenorphine's been out for so many years, but look how long it's taking it to penetrate into regular medical practice. The same thing can be true. You know, you could have people in NA who said, well, we did it like this for 20 years and we don't really want those people to talk. So it could be sort of a cultural thing within the community,
Sure.
even if the national organization is.
Every group is
recognizes
different.
it and is able to let them share.
Yeah.
So I would imagine that like any, I mean, if you look at NA, they have 67,000 meetings a week in the world. It's going to take some time to get that information
Yeah.
everywhere. Yes.
But the point is that, you know, the self-stigmatization and even, you know, just on a weekly basis, I have patients who say, Well, I really do the best when I'm on buprenorphine, but I just really want to be off everything because I feel like I should be able to deal with this, And it's sort of like me saying, well, I can think my way into lowering my blood pressure, but I don't think that's a long-term strategy. I maybe do it for a minute, but
Or their
if-
family is actually.
Or the
against
family,
it. It's a
yeah.
big stigma in the family. If they're on it, this culture that we have.
right. And they're actively encouraging them to get off and, and that puts them at really high risk of overdose, higher than usual, but anyway, so it's, and it's been a journey in the addiction field because I have a lot of colleagues around the country who are abstinence-based to death, that's just going to be, and it's been hard to say, yeah, I know if you can do abstinence-based, great, but if the option is you'll die or you'll be you'll be abstinent and die, or you'll be on a medication. Some of them will say abstinence and will risk death. And I'm like, that's crazy, in my opinion.
Well, we have to teach people too that not all addictions are created equal. And opioid use disorder is a different animal than alcohol use disorder. You have to be abstinent from alcohol to cure your brain, right? Opioid use disorder, very different. You'll have like a 90% relapse rate if you're not on MAT. So
Yeah.
this is the difference, right? Methamphetamine, abstinence is key. Not the same with opioids. The long-term effects on the brain from opioids are very different. They're not creating any sort of breakdown of the tissue or changes in the physiology to the extent that you can't function, right? I mean, you look at methamphetamine and you see all
So
kinds of movement
neurotoxic.
disorders and things that evolve, and that's not the case with opioids.
And the opioid receptor system is simpler. I mean, well, not simple, but it's more straightforward. Like you can take a medicine that goes to that opioid receptor, whereas with methamphetamine and alcohol and cocaine and everything else, and cannabis, it's like there are all these other receptor systems involved at the get-go. But opioids, I mean, it's kind of one of the beauties of treating opioid use disorder because you can actually target a receptor.
There's still brain changes, right?
Yes.
Which creates the imbalance and the dysregulation and the disease at all, right? This is why this is why this is a biologic genetic-based illness, right? Some people respond in a certain way to opioids, which leads to a use disorder, and some people not, right? But this just means that we should treat it like any other medical biological problem.
We lump everybody in and call them drug addicts, but drugs are not created equal. And it kind of look at it from like the LGBTQ community. Look at how long that acronym keeps getting because not all of those people are created equally, but then we still just call everybody a drug addict and don't really dig into, what the impact of the different drugs are on an individual and the treatment options and how that varies. And it's still like the topic that we just want to sweep under the rug and not talk about. That's, really hindering, especially with the growth and availability and issues that we're seeing. Like we just can't afford to keep doing that. But
Well, when you have a marginalized population that's stigmatized or whatever, ultimately in society, the thought is, well, so what if they die? Because they're really not that important. And that's kind of underneath all this. It's sort of like we are facing some of these issues with some of the racial issues that we're facing in our country and how we've sort of turned a blind eye to so much for so long. And I see that happening with addiction, that patients are seen as less than, they're seen not as people, but as, just whatever pejorative term gets used on that day, so that they can be dehumanized.
Deb, wasn't it you that told me one of the law enforcement individuals in one of your counties, we will not get any more specific, once told you that was God's way of like punishing them for using drugs and getting rid of them?
What he
Overdose.
said was, survival of the fittest.
Yeah.
The Darwinian approach.
The opposite, I think it actually holds some water. I think it was David Deming said that the system is designed to get
Exactly the
result
results.
it gets. The system we have right now is designed to kill you.
Yeah.
Exactly.
Has anybody explored the possibility of having the pharmaceutical companies have every other.
Right.
And patients aren't aware that there's treatment out there. It can be
It's
used,
a very interesting point.
and they can go to their physician and ask. I'm not a big fan of. pharmacy companies.
Direct-to-consumer advertising is problematic.
That's its own problem.
We should have thought about that when we were settling lawsuits with Big Pharma and included in there, that they had to put so much money towards advertising MAT. That would have been, that's actually would have
There's
been,
a lot of things we were short-sighted with. and
Yeah.
It's just an alternative. I don't think Utah's in a position. to start
No.
but
you know,
thought of an interesting way to go about it.
and
The other one that always gets me on this topic is there is you've got multiple levels of complexity. But every physician already knows 30 people in their office. It happens.
At
They
least.
don't even have to think about it. If you stop and just redirect them, say, you know, 30 minutes. No, I don't. They're in your office. These are the ones that call 3 weeks in and they're always out. Concentrate on those. That way you don't have to have these people. You could even use that term with the 12 people. Like,
But then they have to confront their own guilt about contributing to their problem.
it may be, you know, the finer part and broad stroke, that's a different solution. You know, that one takes a different thing. But every physician, every provider knows 30 people. With
Oh, at least.
Go after it. We can take that approach and say, you take your 30, you take your 30. We can go a long ways towards at least making a dent in the problem.
Marcy has.
I'm just wondering if medical schools are now implementing that as part of curriculum, or if it's still not even at that.
You know how valuable real estate is now in Utah? Medical school hour curriculum hours are much more valuable than any real estate you can think of. And except that we are going through this thing called metamorphosis, which is going to sort of like blow up the curriculum. But around the country, there's on the whole, there's very little education about addiction. And yet the students know, because they're now coming in with their cousin overdosed or their sister's addicted, or, you know, it's coming down into everybody's family. And they're wondering, when are we going to learn this? And they get 2 hours in our curriculum right now.
Well, we don't do nothing on medication assisted.
We might touch on it.
I think more and more, because there's a lot, I mean, I have more med students and residents and people come to me and say, how did you get into this? What do you know, they're interested.
They're more interested.
But they usually find out about it outside of medical school.
I had it in my medical school training, but I think it was, I remember meeting the addiction psychiatrist and being like, you're the coolest, you know, like, I want to be you. And
Here
she
you
did,
are.
well, I'm here I am. But she definitely had a different perspective, right? It's pretty unique to have.
What about starting a nursing school? I'm a nurse educator for Dixie State, and as a clinical educator, I put students in the hospital, and they see this and they're scared of it. They've never even heard of it. They don't teach it in, the farm classes. They don't teach it in anything. They don't even hear about it as they're hitting the floor. It's brand new nurses. They don't even know how to give Narcan. It's not even part of their skill set.
It's like the redheaded stepchild of medical training. We also don't teach med students how to talk about race or gender or any of those things,
Or
right?
sex
So
or whatever.
anything that's kind of controversial, regardless of how much fact and data we have, we just skip over it.
One thought I'm having is that as the field pushes more toward integrated behavioral health, where you've got the therapists as well as the medical providers in the same room, perhaps some of the education that the therapists receive. When I went through school, they talked about the abstinence only, the moderation, the harm reduction, and they really emphasized the benefit of when all of those are appropriate. And so when therapists do meet together with the doctors, that may have, I'm hoping, that'll have some benefit, but some therapists do feel, as many people who specialize, well, I chose not to specialize in substance abuse, or my background is so insufficient. So education on so many levels would go well there.
Yeah, in medicine, what we do, like if I get a patient who's got heart problem, what do? I don't say, oh, I'm sorry, you have a heart problem. I send him to a cardiologist. But primary care folks always have patients who have addiction and they're like, oh, well, I don't deal with that.
Mhm.
And then that's about it. And it stops there, which is really not, it needs, that kind of stuff needs to become malpractice,
Yeah.
basically, on a regular basis, so that they, but we're in that awkward position where we don't have enough of a specialist. We never will. And so we're gonna have to work through primary
Mhm.
care, you know, in this boots on the ground kind of way, so that you can learn enough as a primary care provider or somebody working in one of those offices or whatever, so that you can do no harm. You know, you don't just give them a big old opioid prescription when they're in
Mhm.
withdrawal. But then you try to get them referred. But that's where it breaks down, because if you're outside Salt Lake County or the Valley, you know.
Yeah, and I
like,
think a
there's
lot of
nothing.
primary care too, like when I came into Moab Regional, I'm the only psychiatrist there. I'm the only addiction person really in the area. Not even just in Moab. I was trying to think who else was there. There's you know, therapy and psychotherapy groups and stuff like that, but in terms of medicine. And I think a lot of the doctors were really worried that I was going to come in and do this, you know, and shame them and make them feel like they've been doing it all wrong, and that I was going to come in and just take things over. And part of that is what they wanted. They did want me to come in and take
Here,
it over.
you, hot
Yeah,
potato.
they did want to just throw me all of their people with SUD, but and they have. And I think that speaks to kind of the rural burnout too, is that a lot of doctors are doing the best they can with the resources they have, and we want to be generous and gracious about that, because they're doing things that we don't do, right? Nor do we want to. So, but I think ultimately too, this conversation in medicine has to do with the stigma that doctors feel about prescribing, period, and wanting their own kind of individualized style and control over their prescribing practices, to be able to do what they feel is right,
Mhm.
but also to teach them really what ethical prescribing looks like, right? And that can be kind of a dicey conversation with some people.
And this conversation really leads well to kind of some conversations I had with Dr. Hal and with Adam and beforehand, but you can, given, you know, how little education a physician actually receives on addiction and I want to relearn my terminology.
Medication for addiction treatment.
For addiction treatment. Everything changes so constantly, but for MAT, like just changing a regulation and saying, oh, hey, you can just start prescribing now. Like, what provider is going to go, oh yeah, I know everything about addiction that I feel like I need to know to do this. I'll start prescribing. Like, so eliminating a training to be able to prescribe, to me, really does not accomplish anything, because I'm not a provider. I've never been through medical school, but I know a lot of providers. You know, I was pre-med, so I've got a lot of doctor friends, and like I interact with a lot of doctors. I don't know that I've met one yet that would be like, oh, I've never prescribed medication for addiction, but you know, I'd be comfortable just jumping in and doing that anytime. Like, or any other area. Like, what other area in healthcare would a doctor just jump in and start doing something they haven't been trained to do? Like malpractice lawsuits all up the yin for that, right? Like, you know, you're up against enough risk as a physician. You're not just going to jump into something like that blindly. So, you know, the current administration's idea to eliminate that, it really didn't change anything. We have a couple providers in Kanab that we're working with a little bit who do, you know, they haven't jumped into this yet, but they have interest in treating addiction with medication. They have interest in learning that, but they weren't about to start prescribing. They actually still wanted to go through the training and learn more about it before they even started really seriously contemplating it. So we wavered one, and the other two that are there, family practice and Kanab, are also interested in doing the same.
Interesting opportunity with Dr. Howard, where some physicians and medical students came down here and out, get on the Dutch.
Yeah, so in our HRSA grant, what we do is we've had our HRSA funded addiction fellows rotate with Dr. Prest, and we're going to start this year. We've started with some rotations at UNHS, but we do make a site visit to Price, and in that time, we try to work in a harm reduction visit out into the community.
And I'm always so impressed with when it's finished. how much they learn in just those few hours and how much more compassion they have for the folks that we serve.
Yeah, and it's kind of interesting because not, the goal is to get people interested in rural, tribal, and underserved areas. And a lot of people, they may be interested in underserved populations, not necessarily rural, but even the ones that are not, the kind of things that they learn, it just amazed me because we have them write a summary of, and one this year said, I was very skeptical about this visit, and then just went down this whole list of all the things that were more related to social determinants of health and how rural communities could come together and cut through some of the barriers. And it was really impressive. And if that's all this person learns in the year, that I think is a great accomplishment, but hopefully they'll learn more than that.
Like, just as we're sitting here talking, there's the big push of like stop the opioid epidemic, stop the epidemic, this whole movement of like stopping overprescribing and that aspect of it. And so in that, we have really moved towards telling our clients and our people who struggle with this, like, you have to be your own best advocate. You have to go to the doctor and tell them, I can't take this medicine, or I'm in recovery, I can't take this. And so I'm just curious if you've seen like how that's affecting their ideals on MAT. Like if we're telling them to go to the doctor and say, I can't take this medication, does that make them more hesitant for MAT medication that might be helpful? Is that having any effect?
I don't know if those specific situations are related in my experience. I think it's always a challenge when folks have to interact with non-addiction trained professionals. They do have to do a lot of advocacy. I don't know if there will ever be enough true understanding from most providers about potential consequences of giving controlled substances to someone with SUD.
Yeah.
I think that's just the tragic fact of life when the cross to bear, right? When you have any health condition, you have to sometimes teach people about yourself that way. And it's not just addiction, right? I mean, you can go to the doctor and be someone who's got any health condition and have someone dismiss you or not listen, right? Or not respect what you've said. I think that's a very common experience for most patients. So I don't know. I can't say that we can change that one very quickly, but hopefully with the more education we give our providers about this, at least they'll screen more effectively.
I don't think providers understand why that's so important. And I could tell you many, many stories. But I have patients who will go and tell their provider, I'm in recovery, I shouldn't take anything addicting, and get put on benzodiazepines because the provider doesn't think that those are really addicting. And I'm like, okay. So I have a website where you can go and like download this brochure that lists everything that's addicting and why. And there's things that are class A, like really don't take these. Class B, these might be a problem. Class C, these are probably okay. And I didn't write the pamphlet, but it's a great resource. But like I had a friend once who went to the doctor, had a headache, and the doctor said, I'm going to give you this medicine. And he said, well, I'm in recovery from cocaine and alcohol. And the doctor said, oh, there's no cocaine or alcohol in this. But what he had given him was Fioricet, which has got a barbiturate in it. And the reason he had headaches was he was hypertensive, and he didn't give him any blood pressure medicine. And I'm like, that's crazy. What are people thinking? So you can do all the right things to protect yourself and still be very vulnerable as someone in recovery.
There's also the flip side. I'm an anesthesiologist, and I've had a dozen conversations with them. I can't remember. Like, well, when you're under anesthesia, they were like adamant. So your messages get accrued, but it sometimes it's a little like when you're asleep, it doesn't matter, and I can't give you this answer. So that's a problem.
Well, in some ways, though, I would have to disagree with you, Mark, because one administration of an opioid, even when they're under anesthesia, can trigger that process again. I've seen it happen before. So to be perfectly safe, they're right. But who's going to have their chest cracked open without any opioids?
Well, and I'll do this later, but our literature would say it's not.
Well, yeah, I'd like to see that because I've just had too many.
Can I share with you a story very quickly? So my daughter's in recovery and she just recently had a hysterectomy and she didn't want anything, right? So we talked that through with her physician and as a family, because we're super involved in that. And she decided to go ahead and take the opioid for 3 days. And okay, so this is terrible to tell you, but we have a joke, right? So if she gets addicted again, we're just gonna send her back to recovery because, well, this is my daughter's words exactly. Recovery is wasted for newbies. Who doesn't want to go for 30 days and work on themselves? You know? So, I mean, there's options, yes. I mean, that's a lighthearted and a silly story to say, but it is true. I mean, and opioids do have a place.
Well,
in
I'm
our
actually
world.
not talking about people taking stuff home. I'm not talking about
Yeah.
prescription, I'm talking about
During the surgery.
And they do have a place in our world. They simply do. I mean, they're amazing at what they're able to do. It's just the repercussions of overprescribing and the accessibility that we had from 1999 to last year has put us where we are. But
Yeah, but there's so many, I mean, what you're talking about is like giving somebody a little fentanyl or something
Yeah,
during
yeah,
their
yeah.
procedure. And, you know, I mean, I don't really think that I would want to have a colonoscopy without propofol
Right.
or
Me too.
something. And so, you know, but for some people, that exposure can trigger the sleeping giant is what I call it, where they come out and they're like, I don't know why I'm having all these using dreams. And I hear this, you know, this is the kind of thing that I don't know how easy it is to really research because it's more subjective and having done it for years, that's what we hear a lot.
I totally agree. Yeah, I think it's really risky to expose anybody to anything. And I think I've had lots of patients who've had surgery and they get 1 dose or something like that, and
they're all cute.
they are
Off to the
gone.
races.
Yeah,
Opportunity for peer support to walk that person through.
right.
Exactly.
And for you physicians to educate, this probably will happen. What can we do now?
Yeah, the alternative isn't always no controlled substances when you're undergoing surgery. You have some sort of procedure or intervention, or you have. I had a patient just go through. He broke his ankle, had it repaired, ended up with a PE. He was hospitalized 2 or 3 times in the course of all of these repercussions. He was getting more and more the opioid exposure through all of. He had intractable pain. It was terrible for him. He's been on Suboxone maintenance for years, successfully, totally stable. And he's been devastated by this. And he has a lot of support and he's still struggling, but he still sees me regularly. He's not off and gone. His Suboxone dose is higher, that's for sure, but he's doing okay because we made the plan. He's got the right supports. He's still in the recovery world. We've made medication adjustments. So it's possible to do it successfully and have reasonable outcomes. But the risks are real and we have to be really careful.
And that's one thing that it's a really good way to damage a relationship with somebody in recovery is to say, oh, no, this is not going to happen because it can. And whatever the research says is what the research says. But and so, for example, you know, what I'll say is if you need opioids in a procedure, either before, after, or during, then talk to your anesthesiologist, surgeon, or whoever about not giving you the one thing that really floats your boat. Like the brain is so specific. Like I have had plenty of patients that would kill for hydrocodone, but oxycodone didn't do anything for them. It helped their pain, but it didn't trigger that reaction. Now, I think they're lucky because then they have that's an option. Or, you know, fentanyl used to be an option, but now I think it's less and less so because it's so much on the street. So non-opioid treatments or opioids that don't really trigger that instantaneous reaction for you. Obviously, we don't use heroin for pain control here. So that can be avoided. It really can help. But you know, you can do all the right things and you can be so triggered, or you, like this guy, have so many things where you're having to have, you know, pain management through intractable pain, that your poor brain is just inundated with stimuli about it. And then it can also cross addiction. I think it's a real thing, although it's almost impossible to research that. But people who've been sober or off alcohol for years, they get older, they have a knee replacement, and they are off to the races with opioids and die from it. So, you know, I know these are things that are anecdotal, but for anecdotes, I think what it tells me is we had to look into some of this stuff. We need to do some more in-depth sort of evaluation or research about this so that we can help protect people better.
Along the lines of what you're saying, that's one of the reasons we so strongly encourage being part of the recovery community, so that when these things come up, you're already prepared.
Yeah.
Be in touch with your NA meetings, with your therapist, with your aftercare, with your any treatment that you've had, so that you are prepared and you've got an action plan before you go in. So you know the before, during, and after plan.
Yeah.
And potential side effects and horrible disasters can still happen, but we've got an already established recovery community.
And I'd be remiss if I didn't take this opportunity to bring in I think that the fact that we haven't touched much on this to this point in the panel kind of illustrates this point, but you know, kind of the whole point of this panel is to update what the changes in MAT waivers has done to MAT in the community. If we want to see real change in MAT and real change in stigma and view of the community, one of the areas that we've got to put more focus in that we just don't seem to connect is the judicial system and law enforcement. They carry a lot of that stigma with them as well. That impacts the physicians. But, you know, when you talk about the successes that we do see with MAT, with, you know, individuals who are in jail in those populations, and, you know, the what's the abbreviation? Probation and parole, and all these different legal programs, because most of these drugs are illegal, and so they're getting in legal trouble as well as the healthcare issues. And I feel like, you know, if the federal government and our healthcare system really wants to move the needle with MAT, one of the areas we should be looking at is how do we involve the law enforcement judicial system in this whole process? Because, you know, they probably a lot of anecdotal stuff as well on my end, and just things I've heard from working with my community partners. But, you know, sometimes you have judges that are really understand addiction and really understand the power of MAT and encourage that. Sometimes you have ones that just don't have any understanding of that and don't view that as an option, don't view that as a solution. And, you know, a lot of the stigmas and things that we've talked about as a panel, I've heard those same stigmas come from the judicial system and law enforcement. And, you know, we're working hard to educate providers, and we're not doing a good enough job of that either. But what are we doing to educate the judicial system about the power of MAT, and what could they do to encourage it? Because, you know, at the end of the day, a cop in uniform still has an authority for a physician. Like, you know, I know physicians are very held at a very high esteem in our community, and as experts as they should be. But, you know, law enforcement's held at that same esteem as far as being an authority and you know, sometimes something to fear more than to help. But if we don't bring them into this conversation and make them a part of our solution, it's a part of the community that's missing. But really feel like if we're only focusing on the clinical side, because they're the ones that prescribe MAT, we're not going to get anywhere, because we need the recovery community, the clinical side, the behavioral health, public health. That whole recovery community has to be involved in this. And I feel like there's missing connections among all of those partners that are preventing real change in the way MAT is functioning in our communities. So I didn't mean to stop the conversation with that, but I feel like law enforcement's largely ignored in this topic, and they should be one of the primary partners that's involved with the whole
They
process.
have to be,
They
yeah,
have to
because
be.
our people are getting in trouble related to their substance use, and it's inevitable.
And look at, like, Cecilia has a whole campaign from Four Corners that your first response was my second chance. Look how I could call some individuals and get them on a panel who could tell you that, you know, it wasn't the physician or the prescriber, it was the law enforcement individual that got it. that made the difference, because a cop was compassionate when they arrested them for drug use and helped them get into that process. And I've had the flip as well. I've heard some horror stories about, the comments that law enforcement have made to individuals who are struggling with addiction in the process of arresting them and booking them, and how much damage that does too. And, if we want to change that stigma and get, our substance use community to actually want MAT and get providers to view it as a useful tool, because I think that's the legal side of things, the illegal substances, the arrests, all those things, I think plays a huge role in the provider's viewpoint. They don't want to get involved in all that stuff. I mean, correct me if I'm wrong, but I would think as a physician that anything that gets you into the legal system is probably something you want to avoid for fear of malpractice and things like that. So, I mean, it just feels like that legal part of things really hinders the clinical community from wanting to be more involved in this process.
That is a little more. They work with behavioral health teams, but for law enforcement in our areas, maybe not quite so much. They're not as open to it. They're still under that idea that it is, it's just preventing another drug for another drug.
Mhm.
So I think, and again, it's that education. Us to know those pieces of education in the moment. So when we're with law enforcement, we have to do American training with our law enforcement here. It's an opportunity to put in a little piece about language and a little piece about medication treatment. It's, those moments where we can put in pieces.
I agree with you. And I also think it's empowering to give tools to people, right? Because they're so used to seeing, the same people have the same problems over and over again. They've watched people die. I mean, this has been a huge source of trauma for our first responders. And I think giving them tools where they can feel empowered and watch people get better, right, is really where it's at, and like I've outreached our police department about syringe exchange, and they basically were like, well, it's not illegal. That's all he could really say to me about it. And so I was like, great, well, we're going to do it. And he was just like, he didn't really have anything to give me about it. But my hope is that when our methadone clinic and recovery center is open, that our police officers and sheriff's deputies are dropping people off at our center instead of the ER or taking them to jail, because then we can intervene when they need us the most. And those officers and deputies will feel like they actually did something for that person that changed their outcome instead of just this revolving door problem.
I think you're right.
It's good because if they see one success story.
You can tell when you work with people in law enforcement or in clinical when they've seen a success story, because it changes everything.
Yeah, and just one story can change that one cop that changes 5 of his buddies.
And the same goes for like our ER physicians too, because like one of our ER docs, he's really hardcore about addiction. He doesn't get it. He doesn't really want to. But he started to see people not come in to the ER, and like when they come in, they're there for something like purely medical, right? And he's a believer now. And now he like called me the other weekend and was like, can I give buprenorphine to this person and have them see you on Monday? And I was like, what? Like, that's amazing.
Yeah.
So it's pretty cool to watch those real life experiences play out.
What was your comment on that?
Well, just the same things what I was going to say. And sometimes we'll take a group of people on a trip to see all the different places that do treatment so they can see the steps along the process. Because if they're only there for the intake, they don't get to see the benefit at the discharge. And if they can see some successful discharge and successful living, then it really inspires the beginning of the process for their portion of the process. I mean,
Yeah, because, most of addiction exposure that medical professionals have, at least, is more the crisis stuff. And if you think, if I thought that everybody with, bipolar disorder was always manic and running around the emergency room, I wouldn't have very much hope for the treatment. But, you follow somebody longitudinally and you see their lives completely change, with bipolar or with addiction over long-term treatment, then you're like, whoa. And then, and it's almost like there's, with peer support, it's almost like people are not even believing that the peers used to be as sick as the patients that they're seeing now. And so seeing that process is really powerful.
Mhm.
With the campaign, the first response, with my champ that we created. I mean, yes, part of the, you know, the kind of, the thing you see is the feel-good story of like this officer helped this individual in recovery and, but there was an underlying agenda with that in that, yes, that story matters, but the point was to have people who don't see people get into recovery, see these stories of
Mhm.
people recovery. Because they're, you know, professionals, you know, they see them come in, but they're not seeing the
Mhm.
individuals that do get better, and law enforcement's not seeing, you know, so a lot of the time they're just seeing them come back into the system. And so the point of it was to be able to have those individuals see that people do recover and that what you do does matter.
Mhm.
Even if you're seeing these people come back in, you know, it could be that next time you see them that could get them the help that they need.
Yeah, and one of the things that I think is worth thinking about with stigmatization is that one of the ways you stigmatize people or a group or whatever is to talk about these dramatic stories like, oh, you know, this person used 5 grams of heroin in a day and they didn't die. And people are like, oh, how can that happen? You know, it's sort of like the crack baby
Mhm.
thing that went on years ago, or the, you know, whatever it is, or people get all bent out of shape about crocodile. Well, who's seen much of that in this country? I mean, it's like, you
I
know,
don't even know what that is.
well, you don't need to. It's not around here, I don't think. But, you know, there are things that it's like this sort of sensationalizing. It's sort of like the National Enquirer approach to addiction,
Mhm.
as opposed to this is a medical problem. Think about it like the New England Journal of Medicine, not National Enquirer, is what we need to be doing.
You know, people might disagree with me on this, but I think it's so stigmatized. I think there are a lot more people out there in the medical community, in the law enforcement community, and community in general, who are more open to these concepts, but they don't express it because they're afraid of. So it's like everybody's afraid to express that they support this. And there are definitely those outspoken ones that don't. But I've talked to so many people that do support it, and I just feel like, you know, it just needs to be a cultural shift that this is okay. And I think you could catch some momentum and really build this much faster, but it's just getting over that hump to get people to accept it. It's okay. It's okay to be, you know, I've got a 2-week-old son who's has no kidneys and is gonna hopefully get a kidney transplant at 22 pounds. He's gonna have to be on a medication for that for his entire life, so that he does not reject that kidney. There's no stigma around that. Nobody's telling me, oh, he's gonna be on medication his whole life. So what if you have to be on a medication to avoid addiction the rest of your life? Why is that not okay? But my son being on anti-rejection medications his entire life is not a problem, but being on an MAT for the rest of your life to make sure you stay out of addiction is for some reason, some really bad thing. And we've just got to get past that stigma, it feels like, and
Yeah.
education is going to be the key to that, but.
Yeah, because I mean, if you think about it, you're thinking about your illness, like if you have self-stigma,
Mhm.
well, it's not really an illness, it's a weakness of will. It's like we talk about it being a disease, but then we treat it like it's a weakness of will or.
Maybe what we need is to start getting with some of these YouTube sensations and social media stars and getting them to talk about it, because if they can get it to go viral, we might make a difference.
Do you see a change in, with the increasing discussion around mental health, depression, anxiety, et cetera, because I think that has been, I wouldn't say popularized, but it's certainly a little more on the public agenda, and people are coming out, talking about it a little more. It's less stigmatized perhaps than it was 20 years ago. Do you see a similar path for this kind of thing?
Well, I'd like to see that, but I don't think the mental health discussions have really spilled over to the addiction stigma. I don't know, Marcy,
I don't think so.
yeah, because it's like, well, you know, we can forgive somebody for being
Right.
psychotic, but if they've been using methamphetamine, then that's like not forgivable. And that's the stigmatization is really judgment. It's really discrimination and saying that somebody's got an unforgivable problem, like it's within their power to, you know, change it.
So oftentimes it goes hand in hand.
Right.
Yeah, exactly.
Yeah, and they're the same, like,
That's
they're
why I
the
wanted to
same
do
thing,
this
right? They're both
pathway.
mental disorders, but.
I see that.
Yeah.
You're gonna have to come to the next session.
Yeah,
was gonna say,
yeah.
we're gonna have to, they've got lunch that starts at noon, which is noon right now, so
Yeah.
we want to thank our panelists for being here. About lunch, people can have other questions they'd like to ask.
Debbie, I'm glad you made that connection. You see our thought process in planning this conference. One topic leads into the
Well,
next.
good to see you. I have to get on a call.
Take care.
Oh, yeah.
Yeah.